Good afternoon, everyone. My name is Jacinta Smith, and on behalf of the PCPCC Support and Alignment Network, I want to welcome you to today's webinar on delivering quality integrated care with an emphasis on patient and family engagement. There are a few housekeeping items I want to go over before we begin. We have a full but exciting webinar planned for you today, so please be sure to share your questions and comments in the question panel throughout the presentation. We will also answer questions at the end. Today's webinar is being recorded and will be made available on our website 24 hours after the live event. The link to our website will be posted in the chat box shortly. You'll be able to access the recording, webinar slides, and other resources on this site by tomorrow. I would now like to introduce our guest speakers for the afternoon. Our first presenter will be Elizabeth Arend, who is the Quality Improvement Advisor at the National Council for Behavioral Health. We will then hear from Eva Nunez-Polino and Marisol Orea from the Acacia Network. We are honored to have our guest speakers joining us today and are eager to learn how their practice delivers integrated care through the foundation of patient and family engagement. Thank you again for joining us, and I will turn the presentation over to Elizabeth at this time.
Thanks so much, Jacinta, and welcome everybody. Thanks for joining us. If we could have the next slide, please. Thank you. So I am a quality improvement advisor with the Care Transitions Network for people with serious mental illness. We are the only practice transformation network within the Transforming Clinical Practice initiative that is exclusively focused on supporting primary care and behavioral health care providers who serve people with serious mental illness or SMI. And so our aim through TCPI is to reduce all-cause rehospitalization rates in this population by 50% while we help organizations prepare for value-based payments. And we do that through one-on-one coaching, providing best clinical practice support services and care transition support. We also offer online data dashboards to help our enrolled organizations track their progress on various clinical quality measures. And we've also produced tools to help stratify risk and understand cost of care. So I'm very excited to co-present with my colleagues at Acacia Network today. They are an absolute model of what we would hope all organizations would do when it comes to behavioral health integration, and they're quite advanced according to the phases of transformation, and it's just been a pleasure to work with them. So I would like to hand it over to Acacia Network so they can share with you more about how they engage patients and families in care.
Next slide, please. Hi, good afternoon, everybody. I am Eva. I work for Acacia Network in the PROS program. I'm the program director. Thank you for joining us. So we'll start by talking about the Bronx, which is the demographic area where we serve many of the population that we have in our different programs. So, historically, the Bronx has difficulty with having good rates in patient engagement and retention in terms of mental health, primary care, substance abuse. There are many medical disorders that affect, our patient population, and many of them do have a diagnosis of mental health condition. On an average, 25 years old earlier, people with a mental health diagnosis also have experienced repeated hospitalization by that time. I think we can go to the next slide, please. So Acacia Network is the largest Latino-led nonprofit integrated care organization. And our success in the integration model comes from having many services within the network where our programs do co-located referral and our clients have co-located referrals within the network. So Acacia has behavioral health programs serving children, adolescents, our mental health clinics, community residential programs, where some of these clients are part of our outpatient programs. The PROS program, which is the program that we introduced at the very beginning. And they also run a 24 substance abuse treatment program on their OASIS. Senior centers program, daycare, residential group homes, primary care services, and a continuum of transitional housing program, which includes shelter and affordable housing for many of the population in the Bronx. Next slide, please. I'll hand it over to Marisol now.
Thank you. So now that you know a little bit about us, we want to segue a little into the reason why we're all here today, which is engagement. In one of our handouts, you'll see that we included a NAMI engagement report that came out last year. And we included it because we found that there's a lot of core principles that sort of reinforce the work that we're already doing and we thought could be really helpful for you guys today. In that report, there was a quote there that mentioned that 70% of people that drop out of treatment do so after their first or second visit. So this really has reinforced, the need for engagement in our programs for our clients, but also for our staff, for the program, and for our community, because as we see, a lot of people drop out of services right away. So we really, really want to stress how important engagement is. And we know everybody who's on the call already knows that. Otherwise, we wouldn't be here. And we recognize that everyone is bringing their own set of unique experiences and expertise. And we're not here as experts, but we're here as colleagues to hopefully bring about some innovative strategies and resources that maybe we can take away from today's presentation. So on this slide, we included some principles of engagement. Oh, you can go to the next slide, Jacinta. Thank you. On this slide, we included some principles of engagement that we took from this report, but also ones that are very close to the values and mission of Acacia Network. The first one is prioritize engagement at every level. Then provide hope and be adaptive. Have person-centered care and strengths-based approach, specifically through shared decision-making, personalized approach to treatment, to include family and peers, integrate services, and then build cultural competence. In the upcoming slides, we're going to go through each of these principles, and then we're also going to provide concrete examples of how Acacia Network is implementing these principles. Next slide, please. Next one, please.
So this is an example of the different ways where you can increase and provide engagement and retention at any program. We'll go through some of these principles. So can you please move to the next slide? So the first example is prioritizing engagement. And the skills that we use at Acacia Network are leadership, involvement, and support. Commitment to ongoing staff development and training, maintaining a clean and welcoming environment to anyone that comes to our program. We also model the engagement throughout all our programs. We have open access hours for services. We also have ongoing consumer satisfaction surveys and feedback. We also celebrate participant acknowledgement, and through these examples, we have recognized and measure that engagement has increased in our programs. Next slide, please.
So the next principle is shared decision-making, and really here the emphasis is just taking into consideration that the relationship between a provider and a client, whether that's a clinician or a primary care doctor or social worker, is just taking into consideration as a collaborative relationship and a partnership. And we have a lot of ways in which we reinforce this work at Acacia. Next slide, please.
So the next slide, this is about this sharing decision making. So the examples include concurrent documentation. So for us, this is really important. We feel that it's really important to be transparent and to do this collaboratively. So our clinicians take this approach and they do it in a few different ways. Some clinicians utilize the end of the session to say, let's summarize the work that we've done here, and then type up the note, allow the participant to see it. In most cases, they co-sign the notes so that we're both agreeing this is what occurred. There's a lot of empowerment in the client seeing their own words, seeing that their thoughts and what they expressed during that session was taken into consideration. The second piece of this is the person-centered assessment, person-centered goal setting. So really, again, emphasis on using the person's words, quoting them whenever possible, taking into account language, and collaborating with them to complete all this. Collaboration is utilized to establish a priority for treatment that is important for the participants, that is not driven by the provider, but rather by the collaborative relationship. So some of the questions we utilize to get to a person-centered goal would be, what are you looking for? How did you get here? Can you tell me what you've tried before? Those are questions that kind of lead us into, tell us your story. Before we dive into, the reason why we're here, let's put the emphasis on what the person came to treatment for. Next slide, please. So certainly the principle of strengths-based approach is something that we take a lot of consideration for anyone that comes to ask for services at any of our programs within the network. So emphasizing people's self-determination and strengths is a must. The philosophy is that, everyone can be resourceful and reliant in the face of adversity. We'll go through some examples of how we use the strength-based approach at Acacia. Next slide, please. So the first thing that we have in this picture is the language matters. So all Acacia programs provide written and verbal communication from a person-centered planning approach and takes in consideration any necessary accommodations that any client that comes through any of our program might need. The second principle on the strengths base is common ground. At Acacia Network, we emphasize that the relationship between the participant, the client, and the provider must be a must. We also have the involvement in decision treatment and making. As Marisol said before, we do collaborative documentation. Treatment planning is collaboratively conducted with any of the clients in our programs. You also have the collateral input. So a point of entry, we make every attempt to assess and connect with anyone who might be a collateral for this particular client. Person that we're serving. We inform the person of the importance of have collateral contact as part of their treatment, and many times it might not be successful at the very beginning, but this is an ongoing process. Every time a clinician meets with a client to address any issues or just to meet for a regular session, the collateral input is brought at every session. The next thing we have here is the shape of services around the participants' goals and interests, not clinicians' opinions and views or needs. So again, it's a collaboration. It's a collaborative process. Participants guide their goals, their objectives, their methods, and in collaboration with the clinician's expertise. So technically meet the person where they at. The next one that you have is recalibrating the goal. So we all don't learn the same way. So basically, if we go through our treatment plan with a client and we see that changes have not been made or very little or no improvement has been conducted, we'll go again through that treatment plan, through the objectives, through the methods, and try to see what is it that the person at this moment can do to get them where they want to be. Next slide, please.
So the next principle that we want to highlight is peer support and involvement. And this really just highlights the importance of us to include peers in the work that we do. Right? So we all know that peer support is a natural way of supporting our peers through difficult times by sharing experiences and being able to say, I've been there, which is a unique thing that we try to incorporate at Acacia. Next, please. So some examples of how we use peer support and involve our peers in our services are as follows. The first one is peer-led groups. Many of Acacia Network's programs have certified peers in both OMH and OASIS that lead groups in several areas, including nutrition, coping skills training, disability education, integrated dual disorder treatment, relapse prevention, wellness and recovery, education, employment, community resources, etc. We really find that our peers are most effective when they're integrated into our programs, just like the rest of our counselors, and that their groups tend to be some of the most popular groups. Because as we said, having someone lead a group that can say, I've been there is very important and empowering to the people in the groups. So we thoroughly enjoy our peer-led groups. We train our peers to be able to lead these groups, and they also utilize their shared experiences to facilitate these groups. Additionally, we have our peers lead our community and advisory council meetings. So all of our programs have advisory council meetings, and some of our programs also have community meetings. So we have our peers lead these meetings where participants get the opportunity to talk about any issues they've had, any grievances, any new ideas, any concerns. And together they sort of troubleshoot those issues. Also, we offer peer support. So whether that's support because someone is experiencing a crisis, support to help find housing, support to enroll in a peer program themselves, our peers lead this initiative. We also have our peers involved in treatment. So often our peers are available to join a participant in treatment if desired. For example, sometimes our peers accompany our participants in their psychiatric appointments to offer an extra set of ears, to offer support, to help advocate for their treatment. So this all depends on what the participants desire, but that is also available to them. And lastly, our peers serve as role models. Our peers who have gone through their own experiences and have completed certified training to become a certified peer serve as a role model and often end up telling, their stories through their groups, through their support, through individual sessions, and guide individuals in how they can do the same. So concrete examples of you can go to this peer academy, you can do this, and just walking them through that process because they themselves did something similar. Today we also have one of our peer specialists here that we thought could maybe shed just a little bit more insight into the work that we do with our peers, because again, our peer support is so crucial to the work that we do. So today we have Alejandro. Alejandro is our certified peer specialist here at our PROS program.
Hello, my name is Alejandro Sanguino. I'm a certified peer specialist. Currently working at Basics, as you know. We do have peer groups. Sometimes if it's necessary, I'll share my lived experience living with mental health and transitioning through the housing system, which I help them acquire housing too, and we meet them where they're at and give them hope, hopefully for them to grow and achieve their goals. I also offer peer support anytime, they have problems communicating with the doctor or talking to the therapist or whoever the caseworker is, and, give them some support and actually be with them while they speak to their providers and make sure that we advocate for them. Peer involvement in treatment, we usually get in touch with their therapist, whoever they're working with, and make sure they're everything is you know, they're achieving their goals of what they want to accomplish. I am also a peer role model. I try to what do I say? A mentor. See, like a mentor. There's another peer specialist here, which he just started, and I also give him support so he can learn what I do to help people overcome whatever obstacles they're encountering.
Thank you, Alejandro. And so he touched on one more important thing that I just want to piggyback on is that our peers have their own support network within our company. And so they offer each other support. Like Alejandro mentioned, he took our new peer specialist under his wing and has offered a lot of pointers and offered to provide additional training to the training that we already have offered him. So I think that's also a crucial piece to helping to retain our peer specialists is offering them on-the-job support in addition to just, you know, their routine supervision and training.
And I think that speaks of Alejandro being our senior peer specialist, certified peer specialist for this program, where he started, you know, without certification and went through the certification process while at the same time he was working, and has motivated not only the current peer specialist, the newest peer specialist we have at the program, but other participants have gotten motivated to become more involved in their treatment and have family members become more involved in participants' treatment as they have put themselves to go to school at this moment. So it has been successful on our end. Thank you, Alejandro. Next slide, please. So now we have the principle of cultural competency. And cultural competency is just demonstrated behavior, attitudes, structures that enable work to be effectively through cross-culturally. Our cultural competence philosophy at Acacia is always ongoing, and we are always trying to look at better practices and how we can better serve the client population that we serve. Next slide, please. So some examples of cultural competence is representation matters. So a very high percentage of our staff within the Acacia Network are of diverse backgrounds who provide services in multiple languages to the different client populations that we have. The next thing we have is the language services. Again, we provide services, individual group services, peer services in different languages. And we also offer translation services, have posted this information throughout all our waiting areas in our programs for people to know that they can receive services in their language. We also have a series of training for our staff. So we do calendar ongoing trainings in terms of awareness of culture changes, cultural issues that might be occurring at the moment. We also have, you know, and all the time taking into consideration the developmental milestone and the experience, including traumatic experience that many of our client population have gone through. So an example of that is that we consider literacy when a person comes into the program. If we are working with a participant that might be a youngster, we might go back and review a treatment planning with this particular individual, goals and objectives that are more suited for that developmental age. We also do many cultural related activities that involve health promotion. So we do acknowledge people's cultures, from different cultures, celebrations. Again, we do complete birthday celebrations. Yeah, that's next slide, please.
So the next principle we want to highlight is integration of services. Basically, this is the management and delivery of health services so the clients receive a continuum of preventative and curative services according to their needs over time and across different levels of the health system. Next slide, please. So what this means for us is that we integrate different types of services within all of our models. One thing we're going to highlight here is what we call our integrated meetings. What these are meetings that we have for specifically one of our primary care programs where an individual is invited along with their family and any friends that they consider. And by family, we mean their chosen family, so it doesn't have to be blood family. They're invited to meet with the primary care doctor, the social worker, peer specialist, their therapist, and a health home representative. So we do this meeting with the goal of developing collaboratively a plan of care. So to address the mental health, the substance abuse, health care, all aspects of the individual's care, right? Because we want to focus on the whole. And so we have these meetings in hopes that if we're all there together, we can all talk about these different components and develop a plan of what are we going to address first. How can the health home coordinator help with this? How can the peer wellness coach help with this? And these integrated meetings occur as needed in our primary care clinic where we have enrolled us. It happens within the first week of initial contact, and then thereafter it happens monthly and quarterly as the participant feels more connected and as needed. And we have found these meetings to be really, really successful because the participant often feels very empowered, they feel heard, they feel very cared for because all members of their team are present. And they also really appreciate that there's thought and consideration given to their family and friends, and we work around everyone's schedule. So we have found these to be really effective. In our handouts, we have included our sample integrated meeting template, the things that we go through in each integrated meeting, things that we highlight, and these are where we also take some notes so that for the next meeting, we can always reference it. And our social workers, health home workers, everyone who participates from the provider perspective also find these meetings really, really helpful because often they're only getting some pieces of the information. They're not hearing about the primary care side in their therapy meetings, and the primary care workers are not always hearing about the behavioral health concerns. So from both ends, they have found this to be really helpful. Next slide, please. So some more examples of things that we do to integrate services is that we offer wraparound services. So in many of our buildings that we have here for Acacia programs, we offer several services in one building. For example, in the building that Eva and I provide our services, we have health home coordination services, primary care services, housing services, different types of outpatient behavioral health services. And we find that just having the access, in one site really helps participants to engage. It helps them to feel like all their needs are being met and that they don't have to travel to all these different places. It makes them feel that, it's convenient for them and they feel that these moving pieces are talking to each other. And so that helps with integration of care and the quality of care. The other thing that we do across all of our programs is that we screen for all needs at intake. So whether it's a behavioral health program or a primary health program, we're screening for health homes. We're screening for behavioral health needs, for immediate needs, for risk, for primary care needs, for dental needs. We have these universal assessments that we use to screen for whatever the participant needs, and then we help to prioritize it. If it's an immediate need and they need a connection to get clothes or they need application for public assistance, we work with that as well. Next slide, please. So this principle that we want to highlight here is just family involvement. And we know that including the participant's chosen support system, as we said, not necessarily just biological family, in sessions can really, really help, right? So we're only here for part of the day with them, but the people that are going to stay in our folks' lives are families. And so what we try to do here is bring them into sessions, provide psychoeducation, provide them with support groups, and include them in the documentation. Next slide, please.
Okay, so as Marisol had just said, meeting participants' needs is our #1 goal. So we wanted to share that one of Acacia Article 31 clinic, which happens to be located in the same building where we provide services, will become a certified community behavioral health center. Next slide, please.
So some additional engagement strategies that we have found to be really, really helpful and effective within our programs are as follows. The first one is the Bronx Regional Health Information Organization, otherwise known as the RIO. It's an information exchange system that works through consumers' Medicaid ID number and allows providers who are part of this network to be able to access information from other participants in the Bronx RIO. So it's an information exchange system that allows us to, for example, with consent, log onto the system and find out what medication or what x-rays a particular consumer did at their other provider. So following sort of this thread of all services allows us to integrate services, but also allows us to be able to provide more effective treatment and interventions because we have the whole picture. Similarly, Psyches works the same way with behavioral health, high health indicators, also works through consumers' Medicaid and utilizes data to inform us if someone's been overutilizing the emergency room, hospitals, length of stay, those kind of factors, which we track from program to program to inform us of the services that we're doing. Another strategy is having access to other services. While Acacia prides itself on having a robust amount of services, there are certain things that are outside of our scope, but we do help to provide to participants. Some new up-and-coming programs that have really been tailored to participants that are high risk and difficult to engage include On Track New York, which helps first episode psychosis, intensive mobile treatment, which is mobile treatment for participants that are historically difficult to engage, that doesn't work on any time frame, that will meet a participant wherever they're at. We'll probably don't hear from our high-risk participants within a certain amount of time. And NYC Well, which has replaced LifeNet, as most of us probably know. And that resource we have posted in our waiting areas. We put it on our safety plans. We reiterate during community meetings to allow participants to connect to resources when we're not available. High-risk case tracking and management.
Yeah, so part of the additional tools that we use are the high-risk case tracking and management. So we do keep a list of our high-risk, high utilizers of the emergency department roster. That list is reviewed periodically. We do conduct incident review committees to review the list of high-risk clients that are in our programs. We discuss interventions and treatment, and the entire integrated team takes part of those meetings. The other thing that we do is that we review these high-risk forms and list of participants in clinical supervision, which is ongoing as a service to our staff and also to assist in the needs of the clients. We do a pre and post test for our group services. So our particular program approach runs groups ongoing every day, every 45 minutes. So we do evaluate the services that are provided in the groups and whether or not they're working, and looking into ways and how we can better improve our evidence-based practice curriculum. We track attendance at our program. through utilizing no-show management policies and rescheduling the same day or the same week as we track attendance. We also have here as an additional tool my kiosk, my choice, which is more of a psyches app that can be used for participants to track their services. We do service utilization reports weekly at programs to see which are the services that the participants are attending. Are these the services that are in line with their treatment plan, or are they going to other services that are not really making any differences in terms of their goals and objectives? We do trending reports, data collection, with the goal of doing quality indicators as a team. Data-driven treatment, again, we collect treatment, treatment plans, review data, whether or not interventions are working. And we do monitor a report and treatment outcome ongoing with the participants and in clinical supervision with our staff. Next slide, please.
So we recognize, and I'm sure we've all recognized, that obviously there are some barriers to engagement and quality care. And some of these barriers include practical reasons, could be transportation, could be financial, could be time or resources, right? If someone is working, if someone doesn't have the money, these are practical reasons why someone might not engage, and we recognize that. There's also other barriers to engagement that include developmental considerations or pre-contemplation, right? If someone's not ready for change, if someone maybe is a young adult and is experiencing a change of heart, a change of mind, and not wanting to engage. There's attitudes and interpersonal factors, right? If there's difficulty adhering to program rules. And then there's always environmental factors. Those barriers being said, there are a few things that we can recommend to help to break down some of these barriers. Next slide, please. So some of the points that we want to stress here that can help break down barriers and are things that we try to do is that we try to provide solutions and resources for practical problems that prevent treatment to adherence. So if it's a financial concern, we offer MetroCard and transportation services for all of our individuals. We help our individuals apply for insurance on site, first visit, if they need insurance, or connect them to that. If it's, they don't have the time to do so, we try to connect them with a program that maybe has hours that are more in line with their goals. Again, being part of Acacia Network affords us the opportunity to tap into some of our other programs and programs in the community. So we have a big list of resources at our disposal. So if there are practical things that we could do or offer to somebody, we do. Develop relationships within community agencies. So again, speaks to, we have our linkages to other community partners. And so whenever we encounter someone that we might feel, we're not best serving or we feel has been really difficult to engage, we might connect them to, say, the intensive mobile treatment program that might be able to go to a shelter, that might be able to go to a halfway house to engage with the participant there and meet them where they're at. Promote adaptability and treatment structure for different participants. Again, we try to be adaptable and flexible. If someone prefers to work with a male provider as opposed to a female provider, for example, we try to make those accommodations. We try to work with people's work schedules, just really trying to be as flexible as we can within our program policies. We provide ongoing satisfaction surveys. These are surveys that we distribute at different intervals. We collect the data, we aggregate the data, and then we report back to the consumers in our community meetings and our consumer advisory boards to just let the participants know these were the results, this is what we found, we're doing good, and these are the areas for growth. And then we develop a plan of action, and we help to implement that plan of action with all the consumers that are present there, and we make it very visible, so it's not a secret. One example of a common grievance that we were having was to change our food menu. And while that may seem very trivial to some, it meant a lot for a lot of participants that we were willing to hear what they didn't like about our current food selection options. And so what we did is that we discussed it in a community meeting forum. We had everyone sort of vote on the top 3 changes they would like to make, which also helped them to collaborate amongst themselves. And then they voted. And then we were able to implement those changes, so they were able to see in the next meeting, this is how we took, your considerations into play, and this is what we did.
So again, we do provide and promote peer and family involvement. As you heard from our full-time certified peer specialist, this is a program that promotes the peer culture. Another peer has been hired recently, motivated by that full-time peer that we have, and is starting the process to get certified himself as well. So we had a good retention in terms of keeping the peers that we have, and also involving other participants and motivating them in becoming peers themselves. The peer is also responsible for conducting outreach in the community to service providers in terms of those linkages that we have. If we have identified that any of our participants have a need that is outside of the scope of practice that we can provide, so the peer goes and conducts field work, comes to certain clients, participants to appointments, and services in the community. We certainly have employed an innovative engagement policy at our program where we are always striving to improve collaboration of care through anyone that the participant has consented and is linked to in terms of their entire treatment planning goals. We also have employed the engagement principle, as you have heard through this webinar, where we try to bring everyone together. We try to bring not only whoever is providing the services to the participants of the program, but in the community, let it be a residential program, wherever that person has someone that can assist, let it be family, blood related or not, we try to bring that person in to really employ the principle of engaging everybody in that person's life. We promote ongoing training, as we said before. We have a calendar of training. Not only we complete mandated trainings as part of our program's regulations, but we do complete staff training, and we have our staff complete training for all the staff. So we involve everyone in the team from a learning perspective to support each other in giving our consumers the best possible care that we can. We also review ongoing data and address any gaps and barriers to engagement. Again, we track reports, no-show reports, participation report, and then we share that with the team, but we also share with the peer. We also share a community meeting, at the community advisory board, and have them, our clients, the participants, come with possible solutions as they want their program to continue to grow. Next slide, please.
So all this sort of speaks to shifting the culture and how we look at engagement, how we look at quality of care. And throughout this presentation, we've referenced the NAMI engagement report that came out last year, because really they helped to redefine how we were looking at engagement as more than just meeting a participant, having them come in. Even the title of the report is called A New Standard for Mental Health Care, and we find that it's really important to highlight that. So one quote that they included there that we wanted to just share was the following. It says, "We would never blame anyone who has cancer for dying, and yet we look upon someone who doesn't get engaged and doesn't get better and assume that he is being obstinate or making a choice. We would much rather provide support. You will eventually get help, but as you go down that slippery slope, it's hard to get help. That must change." So really it's calling for just a change in how we're viewing engagement, how we're viewing the work that we're doing. How we have to really take a look at ourselves and say, you know, if I was a consumer for this program, would I want to engage? From everything from in the environment to the leadership to the visibility of that leadership to the other principles that we spoke about, it's really important to move into a culture that embraces engagement at every level. Next slide, please. And lastly, a reason why we're here today and why this is really important is really value-based payments. As we know, in the world that we live in today, everything is shifting towards, you know, payment for value. And it all boils down to how satisfied are our consumers. You know, satisfied customers, and in this case, you know, while we may not always look at our consumers as customers, their satisfaction is a key ingredient to how much we're going to be able to thrive in a value-based environment. So really, engagement is the core component of that, and hopefully that's something that we emphasize throughout today, because as we all shift towards value-based payments, we want to keep that at the forefront, that it comes down to consumer satisfaction. Next slide. And with that, we conclude our talking pieces here, and I believe there's a little time left for questions, if anybody has any.
Yeah, we have about 10 minutes left for questions, but thank you so much for your presentation. We learned a lot, and you shared a lot of wonderful and detailed information about the work that you do. So we have a few questions. So first, are you able to share some screening tools that you use to identify needs for wraparound or other services?
I think so, yes. We use some tools that are universal, I believe, that are public, and then some others that might have been developed by Acacia, but that we can share. Jacinta, is that something we would send to you and that you could distribute?
Sure, we'll be happy to place that on our post that on our website. So thank you for that.
Okay.
So again, another question we have. So how do you see the potential changes in healthcare reimbursement? How do you think that will affect your program?
That's a great question, and it's something that we think about often.
Yeah.
And again, I think the tools that we spoke about today are things that we not only are, you know, trying to reiterate for everyone on the call, but also things that we try to keep in mind for ourselves in our staff meetings, in our quality improvement meetings, and the meetings that we have with our senior leadership. It's all about, you know, how satisfied are our consumers, how much are our services being utilized, what is the data telling us, what is psyches and Rio telling us, you know, bringing all the information together and making sure that we continue to offer our staff supports to be on top of their training, on top of the treatment that we can provide, and that the numbers are reflective of that. And so far, at least in this program, you know, we've been doing really well with that. We had a recent audit that went very well, and are implementing additional things into our programs to be able to meet those needs. Again, being informed by the data and our surveys, our patient experiences, and any grievances we get, we try to troubleshoot that.
And we also do, we track data weekly in terms of service provision, units of services. You know, we spoke on the webinar about service tracking. So we track data in terms of service provision, attendance to services. You know, that data is shared with the entire team, and within that same week, supervision meetings, we address with the staff, like Marisol said, also in staff meeting, what are we going to do to shift, you know, from this week's data and make sure that we got more engaged and satisfied consumers in our program. So it's not something that we might look at it every once in a while. There are systems, workflows in place for us to review this and look at solutions immediately.
Thank you. So we have another question about your certification process for your peer specialists like Alejandro, who spoke on our webinar today. Is that certification process similar to the community health worker training or certification that's offered in New York?
Different.
I believe it's a little different. Yeah. We can also share, we have like a one-pager information and links of how one can become a OMA certified peer, and it includes taking an exam, having a certain amount of hours, a letter of recommendation, and doing webinars. But we can share that one-pager snapshot of what that looks like if people are interested.
That would be wonderful. Thank you. We have one more question. So how do you select and kind of train or orient your peer specialists or those who are interested in being part of the peer support group?
Well, our peer specialists were all clients in our program were offered to apply for the most recent peer wellness coach position, and we went through a series of in-house clients that apply and went through the hiring process. We also have Alejandro, who is our senior peer, has been here for some time, do workshops weekly with a group of our, participants, clients, where they can get information about, why become a peer certified, what would that mean in your life, and provide, that page of information that Marisol just said, to help them motivate it to get to that process. But we first have looked in-house, and we were successful with that, and the peer that we have more recently was also hire from one of our programs.
Fantastic. And so I think those are all the questions that we have for this afternoon. But again, thank you so much for the information that you've shared. So this will conclude today's webinar, but please feel free to contact us if you have any additional questions about the webinar or the presentation or any of the materials or resources that you guys had in your handout today. Again, the webinar and the presentation slides will be made available on our website by tomorrow afternoon, and the link is in the chat box for you guys to access now. So without further ado, thank you again for attending, and please have a great rest of your day.
Thank you.